other hospitals, and they were looking at medical, surgical, and intensive care units, and only measuring from the point of view of nurses. What is your relational coordination with each other and with each of these other disciplines? And found that to be a significant predictor of patient quality outcomes. And I'll talk about some other outcomes too in a bit. Then chronic care at Cambridge Health Alliance, we found significant reductions associated with significant reductions in unnecessary hospitalizations for chronically ill patients associated with higher relational coordination within the providers at Cambridge Health Alliance, chronic care, and then a big nursing home study in Massachusetts where the association was with higher resident quality of life. So just to put this in context, this is not the only approach to coordination, and it shouldn't be seen in isolation. People have been talking for a long time about reengineering, total quality management. More recently, lean strategies are really important, redesigning workflows, a lot of ways, and I teach ops management, so I think a lot about how do you design the workflow in a way that optimizes handoffs and not just people's individual tasks. But the way I'm starting to see these two going together was articulated by Robert Hendler at Tenet. He said, we've been doing process improvement for several years. We think we're on the right track, but we've tried a number of tools for process improvement, and they just don't address the relationship issues that are holding us back. So he's basically made a case, and a lot of people have now begun to make the case that lean, correctly understood, has a real appreciation and relies very much on addressing the relational dynamics of the work process and not just the so-called technical issues relating to the handoffs. And so one way of looking at it is that something like relational coordination provides the cultural or relational underpinnings for process improvement or lean strategies, and that somehow this means that intervention should really be cognizant of both in a more holistic way. Another way of looking at it is to think that relationships of shared goals, shared knowledge, and mutual respect empower and enable workers to connect with each other in a more meaningful way across the various boundaries that separate them, whether it's discipline, organizational boundaries, and so on. So what is the outcome for workers? Is it something that's, I always assumed that, of course, it just seemed more satisfying to work in a context, so I didn't really measure it early on, but then I did study it in the healthcare study, and people have looked more specifically at it since, particularly in Donna Haven-Sullivan's work. But it is associated with increased job satisfaction, particularly for the further down you go on the kind of traditional pecking order in status. It has it's positive for each group, but particularly the lower status groups. It was a really significant impact on job satisfaction for CNAs, for example, in nursing homes, as well as contributing to resident well-being and quality of life. Increases a sense of professional efficacy, reduces reported burnout and the sense of emotional exhaustion. So I think one of the ways to understand this is that that if there's a long-established finding, I think, in social science, and it's been shown in studies of kids who have traumatic early childhoods, that there are these social factors that help to buffer you from the negative impacts of stress and negative events, and that social support is that any kind of social network contributes. It's like a protective factor, I think they call it in some literatures. And I think what relational coordination does is not only help people get their job done more effectively, which we appreciate as people who care about our work, but it also provides that kind of social context that makes it easier to deal with stress, and therefore provides that kind of resilience or ability to bounce back and persevere under trying conditions. And certainly healthcare is a trying context in which to work. So another way to look at it, just looking at that, it's basically helping to optimize on multiple dimensions at once, which is a characteristic of any fundamental process improvement. So this is really where it gets a little more experimental, where I think about how would we measure and map relational coordination, not just for research purposes, but for actually giving people feedback in a real organization as to what's going on there and how they might think about it and even improve it. Because the question I've been getting for so many years, I'm finally listening to it, is neat. So how do we get from there to there? I'm like, well, I don't really know. I just know I do. You'll see there's a whole high performance work system that is associated with higher levels of relational coordination. But in terms of changing to get to that new equilibrium, it's really a question I have not studied. What is the change process? So one of the keys to doing measuring relational coordination is first picking, well, what's the work process? And it's very similar to lean. You have to pick a work process. You know, what are the set of interdependent tasks that produce some outcome of importance to our organization? And what are those key performance outcomes? Who are the work groups that are actually involved? And you can get really narrow and say, well, it's this core group, or you can keep going back and saying, well, actually they feed into this and they feed into that, and it's the maintenance people who will make sure that you can go bigger or smaller. It's kind of like framing a picture, how big you want to get. You then create a network map to kind of visualize who's involved, and then use the survey, which I'll show in a moment, to measure these ties between those people in those groups. You can map the results and then sit there and even talk about it, like I've done with some organizations. Where are the weak ties, where are the strong ties, and why are the ones that are weak so weak? And often they'll say, well, it's just always been that way. There's a history here, you know. And then, you know, you could start to reflect on that. There's a history, but there may also be organizational practices that help to reinforce that over time, or how we're trained when we're in medical school or in nursing school, all the things that we can start to think about, how does it get that way? So it's not just an individual issue. You start to see it more as a structural issue that can be at least discussed. And this is an example of mapping it out and what that would look like. So let me just show what the questions are. They're just, you know, 7 simple questions. How frequently do people in each of these groups communicate with you about patient care, or care of joint replacement patients, or the flight departure process, whatever is your focal work process? And then you have that answered with respect to, well, the pilots, the flight attendants, the gate agents. So you, under each of those, you have, you're asking, you're identifying what are those work groups, and then rating the frequency, timeliness, and so on of communication with those groups. You'll see with healthcare I added accuracy. That hadn't been there in the original study, and it probably should have been. It's a pretty important aspect of the quality of communication. And this is actually what it looks like. Take the example of, do people in these groups share your goals for the patient care process? And you would identify whatever those functional groups are down the left, and then people would answer this on a 5-point scale. And here is just an example of a map of relational coordination that occurred from a study, an intervention actually. One of the physicians who runs the relationship-centered care initiative was asked to come in and address the issues in this neonatology practice. And you'll see, if you look in each bubble, that is basically the strength of the overall ties, looking at all 7 dimensions averaged together within each functional group. So you see the physicians had pretty much the weakest ties, second only to their ties with the nurse manager. Usually what you see are pretty strong ties within the bubbles because, hey, you know, we're all pilots, we get along, we're all flight attendants, it tends to be stronger within and then it falls off between. But sometimes with physicians you see pretty weak ties within as well. And that can happen other places, but this is the place I've most often seen it, is within the physician group. And this one was pretty troubled. So you can just kind of see where otherwise, you know, the day nurses, the night nurses, secretaries, nurse managers, they all had pretty strong ties with each other. Day and night nurses on the neonatology unit had strong ties with each other. Day nurses, secretaries, night nurses, secretaries. So there was kind of a strong triangle over there. And otherwise, it's fairly weak for an inpatient unit. And so Tony was asked to help. And there's a national organization, I think, that owned these different neonatology practices, and they said, this one is one of our worst. Could you just come in and see what's going on? There was a very multicultural group of neonatologists. They were thought to be, the reputation was that they were uncivil with each other. And so he was asked to focus on the physicians. He used appreciative inquiry. He had a day-long retreat to have them kind of think of appreciative inquiries, basically saying, well, think about a day when things went really well. What was it about that day? How were people interacting? What was happening? And getting people to focus on the positive in order to be able to understand what might be their best self and their group's best self. They got a new physician group leader who did a lot of coaching and goal setting with each of them and created accountability for their relational behaviors as well as their clinical. And